Next, we have Dr. Amit Gupta. He'll be talking about practical pearls for biometry.
Okay. Well, good morning. And one simple fact is that in 8 minutes you cannot learn biometry. That's for sure. So you all have to go back and you have to read up, you have to watch videos, read manuals, and only then you can learn biometry. What I want to give you an insight here in this short time that I have to talk is to how to optimize, biometry. That itself is. So, we've heard about the first intraocular lens transplant. So, who did that? People in the back row. You're aware who did the first IOL implant? Who did the first IOL implant? Quiz question. Which year? Harold Ridley. And in which year did he do? 1949. Right. Okay. So, but are you aware about the refractive error of the patient who he operated? That patient ended up with a minus 20, right? So nowadays, if you are off by more than minus zero point 0.5, your surgery can be deemed as a failure, right? So that is how important your biometry is, and that is why we should try to get to the best of biometry, right? And when we look at improving outcomes of biometry, we are looking at two things. One is customization and the second is optimization. They look like similar terms, but both are like we try to individualize their outcomes so as to ensure a very accurate intraocular lens power in patients. Now, traditionally, if we look at the main sources of errors in biometry, of course, there is the axial length measurement, especially in eyes which are too long or too short, or also there is the K value measurement or the post-operative refraction. But the major, elephant is the prediction of the effective lens position or ELP. So, what have we achieved till now? So, the minimal change in corneal anatomy following cataract surgery. So, with newer techniques, smaller incisions, laser surgery, there's a minimal change. So, the prediction of the change in shape of cornea is now pretty predictable now. More predictable effective lens position, which is whether it's a manual or a laser or good CCC, they all ensure a better axial and lateral centration of the intraocular lens. There's an unparalleled accuracy in axial length measurements, especially with the swept source OCT. And so now, where possible, we have moved out of the ultrasound scans and we have moved into the realm of the swept source OCT. And there's a sophisticated analysis of corneal shape and power. So that be it post-refractive or after ectasia and EKR values and all, they give us a very, very good analysis of the corneal shape and power. And there's a much improved quality of intraocular lenses. Okay, so that also makes the outcomes more predictable. So the bane of this whole thing is the prediction of the effective lens position, right? Now, if you look at various generations of formula, I think you've just been through it. So we had the traditional first generation formula, and then we had the second generation formula SRK2. We had the third generation form of SRKT for Q Holiday, and then the fourth generation Holiday 2, Haggis and Olson. Now, to understand optimization, we have to move out of this generation classification, right? That is third generation, fourth generation, and move on to a classification which is based more on the method and the data which is used for calculating the intraocular lens power. Now, if you look at the SRK formula, I will not ask you that, I'll assume that you know it, but it tells us very well the relationship of the intraocular lens power to certain parameters like keratometry and axial length, right? So an eye with a higher axial length, because there's a minus in front, it will have a lesser or more intraocular lens power. Low or high? Minus 5 or minus 35? Plus 35. Plus 5 or plus 35? Plus 5. It will have lesser. So the lesser the IOL power, the more myopic the eye is, or the more steeper the K is, right? So if we look at the optimizing the effective lens position, right? So this is defined as the distance from the interior surface of the cornea to the principal plane of the intraocular lens. And this is formula dependent, and of course it may differ from the actual anatomical anterior chamber depth. And various factors come into play. For the K reading, what is the K reading? Size of the eye, myopia, horizontal wide to wide. These are all variables which can affect the outcome of the intraocular lens power calculation. So, what we currently are using, we like to rely on them, which are called Vergence formulas. Now, what do you mean Vergence? Vergence is basically, is essentially, it takes into account all the refractive surfaces of the eye. So, it will take into account the anterior and posterior cornea and anterior and posterior lens surface. And therefore, it becomes more and more accurate when we add on variables. So, this is just an overview of all these. So next time you see this, what is Vergence formula, and you have the all these written, and there are certain things which are adjustments for normal, short and long eyes, and this really has to be kept in mind, because the moment you move out of the normal, that's where the blunders and the errors of biometry happen. So again, when I talk about variables, there are formulas with 5 variables, 3 variables, 7 variables. You may remember it, you may not remember it. It's not necessary that a formula with 7 variables is better than a formula with 5 variables. So what we rely on, for example, this is the Barrett's Universal 2 formula. Right now, it's the number 1 formula that we are using, right? So you see some biometer, they say, oh, this biometer has a Barrett's, this has an RBF formula. So it means that it has the capacity to measure these variables and incorporate them into the formula. For example, Barrett's uses K, axial length, antechamber depth, lens thickness, and white to white. So these are all parameters which determine the effective lens position. Now, what is the problem with Vergence formulas? The problem with Vergence formulas is that they are predictive formulas, and since that they also predict the effective lens position, therefore there can be a source of error. And because it's based on a theoretical model, there are fudge factors in analyzing and getting to the real IOL power, right? So, how can we add another dimension to intraocular lens power, or is it really possible for us to add another dimension to the intraocular lens power calculation? And would the results improve if we use the physiological optics rather than physical optics to improve our outcomes? Now, physiological means the eye is a biological tissue, right? And it's a tissue of small dimensions, and it requires clinical measurement combined with physical optics to meet the clinical reality. So this is what is our aim ultimately. Intraoperative biometry is heading towards that, because it actually measures the refraction of the eye and the barometry of the eye in an aphakic position while you are operating, and then predicts the IOL power. So it's been shown to be much more accurate. And the conditions which have the most important role, I won't go into that. I've already said this thing. And how can we customize or optimize our IOL power calculations? You will hear terms like Van Gogh algorithm, even in the chart that I had shown you. So these are modifications for the axial length of the eye. And for example, Abulafia-Koch algorithm. This is an algorithm for toric IOLs which takes into account the posterior surface of the cornea as well. So posterior astigmatism as well when calculating the toric power. So that is how it helps us in improving the accuracy, right? And there are also some other formulas like Ladder-Suber formulas which incorporates the best of many formulas to give you an accurate intraocular lens power reading. Then we have formulas which incorporate artificial intelligence, like the Kane formula or the Hill RBF formula. So what else? So what is artificial intelligence? It's like a little tree growing, right? So it keeps teaching itself, and it grows in accuracy and prediction of the intraocular lens power. So ray tracing or the RBF function is that we have the inputs of some variables. They are analyzed into and compared with thousands of other inputs, and a single output is given, which is in the form of the intraocular lens power. So the benefits of, for example, the Hill RBF is a formula which right now is available on an instrument called LensStar. It is made by a company called Harkstride. So we have it, and in normal eyes, it doesn't really make so much of a difference. But of course, in eyes which are more complicated, it can help us to improve the accuracy. So there is not a very recent, but it's a good publication on comparison of various formulas. So the ultimate thing is, which formula should I use? Okay. So which formula do you really like to use? From the back row, which formula do you like to use for intraocular lens power? Do you use any formula? Which formula do you use in your current setup? Which formula for a normal eye, emmetropic eye, Which formula would you like to use? Entire back row. Any formula? No formula? What? SRK what? No, SRK2 is out. It's in the dustbin. SRK2 is not something which we use now. What else? Okay, so Barrett's is something that you can use, and Barrett's is something which even you can calculate online. Okay, and so Barrett's for us right now the number one is Barrett's Universal 2. Okay, SRKT has shown to have a good correlation. We can use that also in some eyes, and also so I would say that in current world, if somebody asks you, I think if you have the instrument which is giving you a Barrett's Universal 2, you should go in for that, right? Okay. Well, thank you. Hill RBF and there was a chart I didn't show. They have very, very comparable outcomes because Hill RBF availability is much less. It's much less available to users than this thing, but they are very comparable. Hill RBF is slightly more accurate, but not significantly more accurate. Okay, so I would place them both as together. Yeah. So that publication, there was a little chart. I didn't go into that because of the time. It showed comparable. Yeah, but slightly better with Hill RBF. Yeah.